Greetings and welcome. My name is Annette and this talk is on mitral stenosis. Over the course of this lecture, we will look at the etiology, physiology, and echocardiographic assessment of mitral stenosis. First, a word about the epidemiology. As we will learn, rheumatic heart disease is the commonest cause of mitral stenosis. Worldwide, rheumatic fever from group A streptococcus is decreasing, as is the prevalence of rheumatic valve disease. It is the least common isolated valve disease in Europe and has a low prevalence in the United States. It still has a higher prevalence in developing countries in Asia and Africa. Mitral stenosis is a narrowing of the mitral valve opening that obstructs blood flow from the left atrium to the left ventricle. Most patients with mitral stenosis have rheumatic heart disease. However, there is a growing population with degenerative or calcific mitral stenosis. Rarely, congenital heart diseases such as a parachute mitral valve or core triatriatum sinister and Schoen's complex may cause mitral stenosis. Inflammatory causes include lupus, rheumatoid arthritis, and radiation. Prolapse of a large left atrial myxoma may obstruct the mitral valve orifice, causing pseudo-mitral stenosis. Question 1. Which of the following is not a finding in rheumatic mitral stenosis? Is it 1. Commissural fusion, 2. Annular and leaflet base calcification, 3. Chordal shortening and fusion, 4. Leaflet tip calcification, or 5. Diastolic doming? The correct answer is 2. Annular and leaflet base calcification. In rheumatic disease, the leaflets become fibrotic and thickened. Commissural fusion distinguishes rheumatic from degenerative mitral stenosis and identifies disease severity as complete fusion of both commissures usually indicates more advanced disease. Chordal shortening further impairs leaflet tip mobility, creating a funnel-shaped valve with a fish mouth opening. There is thickening and calcification of the papillary muscles and the left atrial wall, creating a coconut atrium. Often, there is sparing of the mitral annulus. Rheumatic mitral stenosis is commonest in females aged 30 to 40 years old. Calcification involves the valve annulus, particularly along the posterior leaflet, with extension to the leaflet's restricting leaflet opening. There is a lack of commissural fusion. The pattern of leaflet thickening and restricted motion is opposite to that observed in rheumatic mitral stenosis. In calcific aortic stenosis, the fibrous continuity between the aortic and mitral valves may become calcified, restricting the motion of both valves. Calcific mitral stenosis is increasing in incidence with advanced age and in patients with diabetes, hypertension, and chronic kidney disease. As diastole begins, the left ventricle relaxes and left ventricular pressure rapidly decreases below left atrial pressure, opening the mitral valve. The pressure in both chambers quickly equilibrates with a normal mitral valve. In mitral stenosis, left atrial pressure remains elevated despite the open mitral valve, as the narrowed valve orifice restricts blood flow. The increased left atrial pressure causes pulmonary venous congestion and elevated pulmonary artery pressures, with symptoms of exertional dyspnea and fatigue. Echocardiographically, rheumatic disease produces thick leaflets of greater than 5 millimeters. The thickening begins at the leaflet tips and extends down the body towards the commissures. Leaflets may be calcified. Leaflet motion is tethered at the leaflet tips, leaving the more mobile body to bow into the left ventricle during diastole, creating a characteristic hockey stick deformity seen in all the mid-esophageal views. The Reed grading system used in transthoracic echocardiography uses the height to length ratio of the leaflets. A ratio of greater than 45% indicates severe immobility. The subvalvular apparatus is involved with chordal thickening and fusion, which shortens the chordae, further restricting mitral valve opening. This is best seen in the transgastric two-chamber views, as shown here. In rheumatic disease, the leaflets are fused at the medial and lateral commissures. This is best seen using 3D echocardiography from the left atrial or left ventricular side. Mitral annular calcification, or MAC, has calcium deposits around the annulus, particularly along the posterior leaflet, that may extend to the leaflet body, limiting mobility. The subvalvular apparatus is often spared. The pattern of leaflet thickening and restricted motion is opposite of that observed in rheumatic mitral stenosis. This is an important distinction, as mitral valve replacement for MAC is technically more challenging compared to rheumatic mitral stenosis. These are two examples of calcific mitral stenosis imaged by 3D echocardiography and shown from the left atrial perspective. One shows calcium along the annulus, restricting leaflet opening, but sparing the commissures. The other is a heavily calcified mitral valve with a pinhole orifice. Question 2. Which secondary finding is not consistent with isolated mitral stenosis? Is it number 1, dilated left atrium, number 2, dilated right ventricle, number 3, dilated left ventricle, or number 4, dilated tricuspid valve annulus? The correct answer is dilated left ventricle. Secondary changes occur in the heart and involve the left atrium, left ventricle, and the right side of the heart. Left ventricular dysfunction may occur. Left ventricular contractility is difficult to assess because ejection can be reduced by impaired LV preload and elevated afterload. Nevertheless, strain has shown that basal to mid segments may have impaired contractility. Secondary changes in the left atrium. The reduced mitral valve flow pulls blood into an enlarged left atrium. The stagnant blood in the left atrium often has small specks of contrast, called spontaneous echo contrast or smoke, that may be a precursor of clot formation. Clots may be present on the left atrial walls or in the left atrial appendage, particularly in patients with atrial fibrillation, and should be excluded by careful echocardiographic examination. Depending on the degree of impaired leaflet mobility, there is often concomitant mitral regurgitation, as shown here in these mid-esophageal four-chamber views. This may confound the assessment of mitral stenosis severity and often requires the measurement of mitral valve area. Elevated left atrial pressure moves the interatrial septum to the right and dilates the pulmonary veins. This transmits pressure to the right-sided circulation, producing elevated pulmonary artery pressures, right ventricular dilatation, and tricuspid regurgitation. The PA systolic pressure can be estimated from the tricuspid regurgitation jet. The degree of pulmonary hypertension is an indicator of the overall hemodynamic consequences of mitral stenosis and is not a direct measure of mitral stenosis severity. However, the presence of severe pulmonary hypertension decreases patient survival. The assessment of mitral stenosis severity uses color Doppler, spectral Doppler, and the measurement of mitral valve area by different techniques. Question 3. Severe mitral stenosis is diagnosed when the normal mitral valve area is reduced by at least 1. 25%, 2. 33%, 3. 50%, 4. 66%, or 5. 75%. The correct answer is 5. 75%. Shown here are the relative circles showing areas. The normal mitral valve has an area of 4 to 6 centimeters. Severe mitral stenosis is defined by an area of less than 1 centimeter squared. Guidelines have established the severity of mitral stenosis based on specific and supportive findings. An estimation of mitral valve area is a specific finding. Supportive findings include the mean pulmonary pressure gradient through the mitral valve and systolic pulmonary artery pressure. It is important to remember that no single value defines severity. Color Doppler shows turbulent antegrade diastolic flow across the mitral valve from the left atrium to left ventricle in the mid-esophageal views. A Nyquist limit is between 50 and 60 centimeters per second. Proximal flow convergence with aliasing of color is seen in the left atrium. Mitral stenosis is easier to diagnose with 2D than 3D color Doppler. In mitral stenosis, the narrowed valve orifice restricts blood flow, so left atrial pressure remains elevated despite the open mitral valve, increasing the time it takes for left atrial pressure and left ventricular pressure to equalize. This is shown by the pressure tracings from the left atrium and left ventricle. Echocardiography does not directly measure pressure, but does measure velocity. The mitral valve inflow velocity is directly related to the pressure gradient by the Bernoulli equation and is recorded with continuous wave Doppler. We record a velocity over time, not a pressure difference, using continuous wave Doppler. Compare the normal mitral valve inflow spectral profile with that in mitral stenosis, which shows the following changes. High E-wave velocity, representing increased velocity across the valve. Flattened E-wave slope from delayed flow through the valve. And fusion of the E and A wave from an absence of diastasis due to the persistently elevated left atrial pressure. Pressure half-time and deceleration time can be used to calculate the mitral valve area. In patients with combined mitral valve disease consisting of significant mitral regurgitation and mitral stenosis, the E-wave velocity is often high, giving a high peak gradient, but the mean pressure gradient is less than 10 millimeters of mercury. Compare the spectral Doppler traces from mild, moderate, and severe mitral stenosis. Note the high E-wave velocity, high peak pressure, high mean pressure, flattened E-wave slope, and fusion of E and A waves. Elevation of the mean transmitral pressure gradient is the hallmark of mitral stenosis. The peak velocity, mean, and peak pressure gradients from the modified Bernoulli equation are all increased. The mean pressure gradient better estimates stenosis severity and is more prognostic. Both peak measures of velocity and pressure are less reliable to quantify stenosis severity, as these are most influenced by left atrial compliance and left ventricular diastolic function. Flow across the mitral valve is variable and determined by the diastolic transvalvular pressure gradient over time, which is influenced by heart rate, rhythm, left atrial compliance, left ventricular diastolic function, and cardiac output. In atrial fibrillation, use an average of 5 cycles with the least variation of R-to-R interval and as close as possible to the normal heart rate. What factors will increase and decrease pressure gradients? Remember, this is the difference between left atrial and left ventricular pressures. A low pressure gradient underestimates mitral stenosis, giving a larger than expected valve area. This can be from low left atrial pressure related to bradycardia or ASD, or increased left ventricular end diastolic pressure, as with low cardiac output, aortic insufficiency, left ventricular hypertrophy, diastolic dysfunction. A high pressure gradient overestimates mitral stenosis, giving a smaller than expected valve area. This can be from high left atrial pressure, as in mitral regurgitation and diastolic dysfunction, or low left ventricular end diastolic pressure, as with increased cardiac output and tachycardia. We should use mitral valve area to assess stenosis severity if Doppler gradients are unreliable. Newer findings suggest that there is a different flow dynamic based on the pathology. Classic rheumatic mitral stenosis has funnel-shaped flow compared with calcific mitral stenosis, which is more tunnel-shaped. This has implications for the pressure gradient across a stenotic valve. For the same anatomic area and flow rate, the pressure gradient is lower for a flat valve shape compared with that of a funnel-shaped by up to 40%. The pressure gradient across the stenotic orifice would be lower in calcific mitral stenosis for the same anatomic orifice area. Many factors influence Doppler pressure gradients, often making them unreliable. Thus, mitral valve area should be used to assess stenosis severity. There are several methods available to determine mitral valve area, including planimetry, pressure half-time, continuity, or Pisa, each with advantages and disadvantages. Planimetry measures the anatomic mitral valve area, which is slightly larger than the functional mitral valve area obtained by Doppler methods. It is best to use several techniques for confirmation of disease and severity. This table summarizes the limitations for the different techniques used to measure mitral valve area. Each will be discussed individually in the next slides. The commonest techniques is the pressure half-time, which, as you can see, is not valid in a host of common conditions, such as aortic insufficiency, left ventricular dysfunction, ASD, and diastolic dysfunction. Importantly, other valve lesions influence the pressure gradient across the mitral valve, so the presence of significant aortic valve disease and mitral regurgitation will require measurement of the mitral valve area. Different techniques should be used, though Pisa will work for all the listed valve lesions. Tracing the inner edge of the mitral valve orifice during mid-diastole using the parasternal short-axis view in transthoracic echo is considered the gold standard for determining the anatomic mitral valve area. This technique correlates well with invasively derived measures and orifice size in explanted valves. In a similar way, planimetry of the mitral valve area by TEE uses the transgastric basal short-axis view. 3D TEE offers the opportunity to align planes through the smallest orifice and trace the mitral valve area. Technical limitations include poor quality images, oblique cuts, and excessive 2D gain, which overestimates a smaller mitral valve area. Since the stenotic mitral valve forms a funnel shape, moving the imaging plane back and forth helps to determine the narrowest part of the valve. Question 4. What is the calculated mitral valve area? Is it 1, 0.72, 2, 0.92, 3, 1.08, 4, 1.20, or 5, 1.40? The correct answer is 2, 0.92. Pressure half-time uses the rate of pressure drop across the mitral valve to calculate mitral valve area. Pressure half-time is the time it takes for the peak transmitral pressure gradient to decrease by half. The more stenotic the valve, the longer it takes for the left ventricle to fill, thus increasing the pressure half-time. In mitral stenosis, the mitral valve area in centimeters is calculated by using the empirically derived formula, mitral valve area equals 220 divided by pressure half-time. It is important to note that this formula is not validated for a normal native mitral valve area after balloon valvuloplasty or with a newly implanted prosthetic valve. If the spectral trace is bimodal, use the mid portion of the trace to calculate the pressure half-time. The deceleration time is the time from peak to zero velocity and is related to the pressure half-time by pressure half-time equals 0.29 times the deceleration time. The mitral valve area can be calculated by using the formula mitral valve area equals 759 divided by the deceleration time. Question 5. Which of the following is true? A. Mean gradient is underestimated with tachycardia. B. Mitral regurgitation underestimates mitral stenosis severity by the mean gradient. C. Pressure half-time is decreased with reduced cardiac output. D. Aortic insufficiency underestimates the mitral valve area by pressure half-time method. The correct answer is C. Pressure half-time is decreased with reduced cardiac output. Pressure half-time measurements rely on pressure differences in flow through the valve, which depend on left atrial and left ventricular compliance. In increased left ventricular end diastolic pressure or decreased compliance from AI, cardiomyopathy, left ventricular hypertrophy, in aortic stenosis and hypertension, or restrictive diastolic dysfunction, this shortens the pressure half-time, giving a smaller mitral valve area than actually exists or overestimates the mitral valve area. In a similar way, altered left atrial compliance from ASD, mitral regurgitation, atrial fibrillation, or tachycardia will shorten the pressure half-time, giving a smaller mitral valve area than actually exists, also overestimating mitral valve area. A prolonged pressure half-time does not necessarily indicate mitral stenosis. Patients with abnormal myocardial relaxation have a prolonged pressure half-time, but the peak E velocity is not increased and is less than 1 meter per second. It is important to remember to avoid using pressure half-time to estimate mitral valve area in the settings of elderly patients who frequently have stiff left ventricles, calcific mitral valve disease, as well as patients with diastolic dysfunction. The continuity equation uses conservation of mass to calculate mitral valve area of the diseased mitral valve by comparing flow across a normal mitral valve. There should be no aortic valve pathology, left ventricular outflow tract obstruction, much regurgitation, ASD, or atrial fibrillation. A limitation to the continuity method is the need to use multiple measurements. It is reliable in calcific mitral stenosis, provided no significant aortic valve disease is present. Shown here is an example of calcific mitral stenosis with color Doppler. The spectral Doppler trace shows a mean gradient of 5 millimeters of mercury and a mitral valve area by pressure half-time of 1.1 centimeters squared. Stroke volume through the aortic valve is calculated from measurements of the aortic valve diameter in the mid-esophageal aortic valve long axis view and the VTI through the aortic valve from a transgastric view. The aortic valve annulus measured in systole was 1.7 centimeters. A spectral Doppler trace is obtained with good alignment to forward flow in the deep transgastric view. In this case, stroke volume through the aortic valve is calculated to be 56 cc's. The stroke volume is divided by the mitral valve VTI to obtain a mitral valve area of 1.21 centimeters squared, compared with 1.1 centimeters squared by the pressure half-time method. Question 6. What is the calculated mitral valve area in centimeters squared based on the information provided? Radius 1.7 centimeters, velocity aliasing 25 centimeters per second, Vmax 250 centimeters per second, and alpha angle 100 degrees. The correct answer is 1 centimeter per second squared. The Pisa method calculates mitral valve flow during diastole based on the hemispheric shape of the convergence zone seen with color Doppler in the left atrium. Mitral valve area is calculated by dividing the mitral volume flow by the maximal velocity of mitral flow. This is a less validated method to estimate mitral valve area, but is useful in the presence of aortic insufficiency, mitral regurgitation, prosthetic valve, or arrhythmia. It is unaffected by left atrial and left ventricular compliance. This method assumes spherical flow convergent area, though the geometry of the isovelocity shells changes with flow rate, pressure gradients, orifice size, and shape. This example shows a calculation of mitral valve area using Pisa in a rheumatic mitral valve with significant mitral regurgitation. The technique uses a zoomed view of the color flow Doppler convergence region. A measurement in centimeters of the radius R of the hemisphere is taken from the alias region to the orifice. The aliasing velocity at the bottom of the color scale is noted in centimeters per second. The peak velocity Vmax of the continuous wave Doppler is measured. Flow through the mitral valve is calculated from the formula. The 1 centimeter mitral valve area and mean gradient of 12 millimeters of mercury represents severe mitral stenosis. In this example of rheumatic mitral valve disease, the color Doppler baseline is shifted downwards, increasing the size of the flow convergence hemisphere. The radius is measured at 1.2 centimeters at a lower aliasing velocity of 25 centimeters per second. The peak velocity from the mitral valve inflow spectral Doppler trace is 255 centimeters per second. Plugging these values into the Pisa formula for mitral valve area gives a valve area of 0.89 centimeters squared, which is severe mitral stenosis, and lower than the 0.95 centimeters squared obtained by the pressure half-time method. For completeness, I've included the pressure measurements, which show a peak of 34 millimeters of mercury and a mean of 15 millimeters of mercury, also supporting the diagnosis of severe mitral stenosis. In this example, also of rheumatic mitral valve disease, the color Doppler baseline is shifted downwards, increasing the size of the flow convergence hemisphere. The flow convergence hemisphere is 1 centimeter, and the aliasing velocity is 35 centimeters per second. The flow convergence is not a complete hemisphere, and an angle correction is necessary. The angle is 95 degrees. The spectral Doppler trace shows a peak mitral valve inflow velocity of 225 centimeters per second. The values are plugged into the Pisa formula to obtain a mitral valve area of 0.52 centimeters squared. There is discordance in the mitral valve area with Pisa and angle correction, giving an area of 0.52. Without angle correction, an area of 0.98 is obtained, and by pressure half-time, the mitral valve area is estimated to be 1.67 centimeters squared. The peak gradient is 20, with a mean of 9. This represents moderate mitral stenosis. Disease-based assessment of mitral stenosis is becoming more relevant with the surge of calcific stenosis. It is increasingly being recognized that these pathologies differ in their assessment. It is apparent that 3D planimetry, Pisa, and the continuity equation are the most robust techniques for assessment. Like low-flow, low-gradient aortic stenosis, there can be discordant data leading to a diagnosis of low-flow, low-gradient mitral stenosis. This represents a mean mitral valve area of less than 1.5 centimeters per second, measured directly from planimetry, mean pressure gradient of less than 10 millimeters of mercury, and a transmitral flow of less than 35 cc's per meter squared. There is a 20% prevalence of low-flow, low-gradient mitral stenosis. This may result from an increase in afterload or LV dysfunction. These patients tend to be older, more ill, have more atrial fibrillation, and more subvalvular disease. Functional assessment by reducing afterload with vasodilators or increasing valve flow with dobutamine or exercise testing may help determine which patients with low-flow, low-gradient mitral stenosis have true versus pseudo-severe mitral stenosis. This may enable better selection of candidates who are likely to benefit from treatment. Valve interventions include percutaneous mitral balloon commissurotomy and surgical repair or replacement. Indications for rheumatic mitral stenosis are listed from the 2020 ACC guidelines. These include patients who are symptomatic and have a mitral valve area of less than 1.5 centimeters squared. There are different indications for calcific mitral stenosis, which also only include symptomatic patients and those with mitral valve areas of less than 1.5 centimeters squared. Recognition is made that these patients are at increased risk from open mitral valve surgery. A word about percutaneous balloon interventions. The Wilken Score by transthoracic echocardiography is used to assess suitability for percutaneous balloon mitral valvuloplasty or commissurotomy. It was initially used for grading of outcome after balloon valvuloplasty. The score uses 4 components: mobility, thickening, calcification, and subvalvular thickening. A normal score is 4, and a low score of less than 9 has a good outcome. There are other scores that have been developed, including the Cormier score and the 3D TE score for predicting success in balloon valvuloplasty. These are 3 quick reads. Echocardiography in mitral stenosis by Dr. Omaran looks at mostly rheumatic disease. How to assess mitral stenosis by echo is a great read for balloon valvuloplasty and nicely summarizes many of the features of mitral stenosis. And Mitral Stenosis in 2019 is a thought-provoking editorial that looks at how mitral stenosis assessment is changing and the epidemiology. Here are some more readings for those who are interested. Thank you very much.